like to invite the first speaker, Dr. Bhanupriya, and she'll be speaking on the topic BRVO. I'll request all the presenters to please stick to time, and exactly 4 minutes the timer will stop. Thank you. Dr. Bhanupriya. Is Dr. Bhanupriya there? Yes. Come.
Hello.
And I'll request Dr. Krutika to be ready on this dais. Dr. Krutika.
A very good afternoon. Today I am going to discuss about a patient, 87-year-old female patient who came to us with blurring of vision in her left eye for 1 month, and she is a known hypertensive for 2 years, and she had a history of 2 anti-VEGF injections given. So this was the right eye, BCVA was 612, and the left eye 660, and in the left eye, as we can see, the posterior pole is there is a wedge-shaped distribution of intraretinal hemorrhage, and with macular involvement is there. So it's a clear case of BRVO, left eye supratemporal BRVO. So what should I do next? OCT or fundus fluorescein angiography. So in the 80s, when grid laser was the treatment of choice for the macular edema and OCT and anti-VEGFs were not invented, at that time FFA was the investigation of choice. But now OCT is the first and foremost investigation we should do. And FFA should be done when OCT was normal. So this patient with 660 vision, there is a macular edema, 1 month post anti-VEGF, vision improved to 660 to 624, and the macular edema came down, and in the 4 months follow-up, 3 anti-VEGFs was given, and there was nearly resolved hemorrhage along with the resolved edema. So now is the time to do fundus fluorescein angiography to look for the ischemia and capillary non-perfusion areas. So when we did the FFA, we saw the peripheral CNP areas and no leaking neovascularization was noted. Then sectoral laser was done. So this is the timeline of the clinical photograph of this patient in the 6 months period. So BRVO is the second leading cause of vision loss after diabetic retinopathy, and we should identify the risk factors, especially in the younger patient. There is various causes of vision loss. Either hemorrhage is sitting on the macula, there is macular edema, macular ischemia, there is neovascularization, there is complications, vitreous hemorrhage. So when BVOS study was there in the 1984, grid laser was the treatment of choice and sectoral laser was done if NV is present. But now we should not wait for the NV to develop, because and we should go for the laser for the stabilization of the edema, to not rebound edema should not be there, and to decrease the number of injections in these patients. So now the first treatment of choice is either steroid or anti-VEGFs. These are the FDA approved steroid. In the steroid category, there is triamcinolone acetate, Ozurdex, and in the anti-VEGF category, we have ranibizumab, aflibercept, faricimab, and biosimilars. So the take-home message is identify risk factor, macular edema is present, consider early treatment, extensive CNP areas, do sectoral laser, look for complication, and save the other eye. Thank you.
Thank you very much, Dr. Bhanupriya. One question from the panelists. Anything you would like to ask?
What is the drawback of Ozurdex versus the anti-VEGF?
Sir, yes. Sir, the Ozurdex, it can give rise to increase in IOP, and the cataract development is there more in the Ozurdex compared to the anti-VEGFs.
What about NV? Does it treat NV? Does it prevent NB or anti-VEGF will prevent NB better?
Sir, anti-VEGFs will prevent and Algidex will take care of the inflammatory part, basically.
Thank you very much, sir.
Thank you so much.
Like to have the second presenter please start? Yes. Dr. Kirtuga.
Good afternoon, everyone. My case is papillophlebitis in a hypertensive diabetic patient, an atypical presentation with diagnostic challenges. Introduction: papillophlebitis is a rare idiopathic condition affecting the central retinal vein in young and middle-aged adults. It is characterized by optic disc edema, venous dilatation, and tortuosity, resembling CR vivo. Etiopathogenesis is unclear, but it is postulated to be an inflammatory or ischemic event affecting the retinal circulation. It differs from CR vivo by its mild to moderate visual impairment and lack of systemic thrombotic associations. Common risk factors include systemic hypertension, diabetes mellitus, hypercoagulable states, and vasculitis. This condition is usually self-limiting, but long-term follow-up is essential to monitor for complications. Case summary: a 57-year-old female came with complaints of defective vision in left eye for past 1 month. Past history: patient is a known case of systemic hypertension and type 2 diabetes mellitus for past 8 years on oral medication. Cataract surgery done in both eyes 6 months ago. Visual acuity in right eye is 6.9 partial, improving to 6.6. In left eye it is 6.24 partial, nil improvement with pinhole. Anterior segment examination of both eyes shows normal. Fundus examination: right eye media is clear, disc is normal, cup disc ratio 0.3:1, vessels shows arterial attenuation and AV crossing changes. AV ratio 1:3, macula is dull, FR is absent. In background, coronal spots is present. In left eye, media is clear, disc edema is present, cup disc ratio is not made out, venous dilatation and tortuosity is present, AV ratio is 2:4, macula shows edema, FR is absent. This is the fundus picture of the patient. In left eye, there will be optic disc edema with tortuous and dilatation of vessels is seen. OCT of left eye shows cystoid macular edema with CMT 16 microns. My diagnosis is right eye grade 3 hypertensive retinopathy, left eye papillophlebitis with cystoid macular edema. Management: since papillophlebitis is self-limiting, treatment is mostly supportive. Most cases resolve spontaneously over months with good visual recovery. Systemic workup for hypercoagulability, vasculitis, infections, or autoimmune disorders to rule out risk factors. In case of macular edema, for mild cases, observation is enough. In case of persistent edema, intravitreal anti-VEGF should be considered. Anticoagulation is not routinely required unless systemic thrombophilia is confirmed. Clinical implication: papillophlebitis should be considered in cases of optic disc edema with venous congestion, especially in middle-aged patients. Differentiating from CR vivo is crucial as management and prognosis differ. A thorough systemic evaluation for underlying vascular and inflammatory condition is recommended. Close monitoring is needed to assess spontaneous resolution and prevent long-term complications like macular edema. Take-home message: papillophlebitis is a rare but important differential diagnosis of optic disc edema. It may be misdiagnosed as CR vivo. Careful clinical evaluation is the key. The condition is generally self-limiting, but systemic association should be investigated. Regular follow-up is essential to detect any complications early. Thank you.
Thank you very much, Dr. Abhinandan. Any question for you?
You said it's a phlebitis, then why didn't you give steroids in this patient? That diagnosis itself says it's a phlebitis.
Yes, sir.
So why don't you give steroids in this kind of
Yes, sir, we can give steroids.
So what is the indication for giving steroids?
Cystoid macular edema is an indication.
Is it different from neuroretinitis? If I say it's neuroretinitis, if optic disc edema and vasculitis, it's neuroretinitis.
Yes, sir. In pupil, relative afferent pupillary defect will be absent in case of papillophlebitis.
Neuroretinitis, it will be absent, RAPD. Yeah, because neuroretinitis is the disease of, and you won't see so many hemorrhages in neuroretinitis.
Yes.
Thank you very much.
Thank
Dr.
you.
Ishan Goel, please take up the next stage, please.
Good afternoon, everyone. My name is Dr. Ishan Goel. I present a case of preeclampsia beyond blood pressure, exudative RD in pregnancy. So preeclampsia is basically a multisystemic disease with a new onset high blood pressure of more than 140/90, generally accompanied by proteinuria. Now in that, HELP syndrome is characterized by hemolysis, elevated liver enzymes, and low platelet count, while partial HELP syndrome will be either one or two of these. Now RD generally affects 0.1 to 2% of patients in severe preeclampsia and 0.9% patients in HELP syndrome. So pathophysiology is similar in this in HELP syndrome as in DIC. So where microthrombi cause hypoxia, which causes significant failure of outer blood retinal barrier, which causes formation of a bullous RD. Now we present a case of a 26-year-old primary gravida at around 27 to 28 weeks of period of gestation. She was admitted in the antenatal ward due to generalized throbbing headache, vomiting, swelling of face, arms, feet, and intermittent vertigo since 2 weeks. She is a known case of hypertension. She was detected at 15 to 16 weeks of period of gestation and was started on nifedipine 10 mg. Now after admission, she complained of sudden onset, painless diminution of vision since 1 to 2 days. On bedside examination, we examined bedside initially and then she visited our clinic. So uncorrected was counting fingers 2 meter in the right eye, and uncorrected vision is counting finger 2 meter at right eye and left eye 6/36, while pinhole showed no improvement. Pupils were sluggishly reactive with increased pupil cycle time of around 980 to 1005 milliseconds in the right eye and 990 to 1015 milliseconds in the left eye. There was no RAPD in either of the eyes. IOP by GAT was 10 and 12, and posterior segment shows large fluid-filled bille seen in the inferior temporal region involving the macula in the right eye, while left eye the macula was not involved, and shifting fluid sign was positive in both the eyes. And bedside confrontation test shows superior and inferior nasal visual field defect in the right eye and superior visual field defect in the left eye. So this is the fundus image. So we can see fluid filled bullae in both the eyes, while it is involving the macula in the right eye. Left eye macula is spared. That also tells about the better vision. Then coming to investigations, low platelet count, deranged RFT, and increased CRP, SR levels were seen, but LFT was within normal limits. So this was a case of a partial help rather than a complete help. And then treatment, blood pressure was treated by the obstetrician and the physician, and they were giving IV dexamethasone 6 mg QID for early fetal, because they were anticipating urgent C-section. Subsequently, she was taken for urgent C-section. Now, after 6 days after delivery, we saw the patient again. Now the RD had resolved by itself, but we can see a macular star kind of formation in the right eye. So and the vision had improved to 618 in the right eye and 69 in the left eye. Now this is a case of partial HELP syndrome with preeclampsia. Now, as it is a stress-induced condition, definitive treatment is the delivery of the fetus. Aggressive blood pressure control and corticosteroids serve a vital role in supporting the RP pump function, therefore promoting the neurosensory retina reattachment. Now, there are no explicit recommendations for this management, but it is advisable to terminate the pregnancy by cesarean section as soon as possible. Now, anatomical sequelae is usually mild, but the functional sequelae, as for example here macular star kind of picture we can see, can vary from case to case basis. Thank you.
Thank you very much. One question can be there from the panel, and till that time I'll invite Dr. Manjot Kaur from the previous session to please.
What do you have the long-term follow-up for
Sir, she is a very rural background patient. She is lost, but I would like to do an OCT as well as to see whether any functional sequelae are there or not, but she is lost to follow-up.
Do you have post-operative vision after 6 days? What was the vision?
Vision 618 in the right eye and 69 in the left eye, sir. Thank you, sir.
Thank you. Yeah, please start.
Good evening, everyone. My presentation is on Chota Packet Bada Dhamaka, that is a microspherophakia. So before we begin with case presentations, let's briefly brush up the anatomy. The lens is such a human organ that starts growing in the gestation but continues to grow throughout the life. So it starts less than 3 months, wherein it is vertically elliptical. And around 3 to 8 months, there is this spherical growth. So it is at this stage that if it gets arrested, it won't grow further, and it will remain spherical throughout the life. So there is this arrest of tunica vasculosa lentis that will persist as a spherical shape throughout life, causing this microspherophakia, and this has been backed up by the MRI imaging in the gestation. So what actually causes equatorial growth of the lens is the zonular strength on the equatorial margins that pulls the lens in the equatorial direction, which causes the increase in the anterior-posterior diameter and decrease in the equatorial diameter. So beginning with the case details, 24-year-old male presented with a routine examination, and on refraction, we saw the patient had -9 myopia. So what do we expect in a myopia case? A deep anterior chamber and probably increase in the axial length. On the contrary, to our surprise, the patient had a very shallow anterior chamber. And also axial length was pretty normal. But the lens thickness was increased. So there was this lenticular myopia. So when we suspected microspherophakia and we confirmed it on AIOS2025, we safely dilated the patient in the supine position and did the fundus examination in the supine position. So in full mydriasis, we can see the 360-degree equatorial margin. And this is the AIOS2025 picture. So the hallmark triad of lenticular myopia, shallow AC, and angle closure glaucoma can be present. Prophylactic peripheral iridotomy was done, and the patient was called up for 6-month follow-up. The patient was doing quite good, but there was another case, the patient with PI and on Dorzox T, still when the patient presented on follow-up, he presented with again a shallow AC and a patent PI. So despite prophylactic PI and on AGM, the pressures were not controlled. They were as high as 42 and 40. The culprit here in this case is not glaucoma itself, but it is a secondary cause due to the microspherophakia. So in such a case, it is safe to do a clear lens extraction because that is the cause of high IOP instead of putting the patient on again AGMs. So on 1 month post-op follow-up, the iris claw lens was placed and the PI was done, and we can see the AC is well formed and pressures are maintained. So lensectomy is effective in controlling IOP without any AGMs in 69% of the eyes, and the other 7.7%, there are some other preoperative risk factors for glaucoma. The take-home message is that observational PI can be done for initially, in wherein the IOP is normal and angles are open, but lensectomy may be required if the IOP is high despite a patent PI or there is phacodonosis or subluxated, since the main seat of pathology is in the zonular weakness. Then the question comes about the indications of IOL surgery and IOL choices. So it can be a scleral
Can we wrap
fixated
up, please?
IOL.
Yeah, thank you.
One question, why didn't you put atropine in this patient? Atropine is considered to reduce the pupillary block.
Yes, sir, but to prevent pupillary block like prophylactic peripheral.
There is only one condition in glaucoma where atropine helps. That is
Inverse.
yeah. This is what we call as an inverse glaucoma. So atropine, if you should try atropinizing the patient, and many a times with that glaucoma disappears. Second thing is that lensectomy is the treatment of choice if you don't get the relief from atropine.
Thank you very much. Can I have Dr. Kritika Jain, please, on the for the presentation?
पिछले वाले session से था.
She will be presenting on BRVO with CRVO, and Dr. P. Lakshmi Priyanka also to be ready with a presentation. Please start.
So, good afternoon everyone. I will be presenting my case on concurrent central retinal vein occlusion along with branch retinal artery occlusion in a young male. CRVO and BRAO are distinct retinal vascular events that they usually occur independently and in individuals well over the age of 60. But it has been seen that their simultaneous occurrence is usually seen in younger individuals. The pathophysiology basically either involves a thrombus blocking the central retinal vein and then slowing the blood flow in the arteries, and then sluggish blood flow again enhancing the clot formation. And then also since it has been more observed in younger individuals, the increased physical activity causes dehydration resulting in hemoconcentration and also then again promoting the thrombus formation. And these are the other systemic vascular diseases, hyperviscosity syndromes, inflammatory causes and hypercoagulable states, which again promote the thrombus formation. So now beginning with the case, a 41-year-old male presented with the chief complaints of sudden painless diminution of vision in his right eye for the past 2 days. There was no such other significant complaint other than this, and the past medical and the family history was non-significant, and the personal and social history was also taken, which includes there was no history of smoking, alcohol or drug abuse, and there was no history of excessive physical exertion prior to the onset of symptoms. The general physical examination was well within the normal limits. The vitals were stable, the systemic examination was normal. The diagnostic workup for this patient was done. The blood profile was normal. On echocardiography, a trivial tricuspid regurgitation was observed, and for which the patient was advised cardiology opinion, but again it came out to be non-significant. Then the ocular examination for the patient was done, and the right eye it revealed a vision of finger counting at 5 meters, The ocular motility was full, adnexa within normal limit, anterior segment slit lamp examination within normal limits, and after that the patient was dilated, and we could see multiple retinal hemorrhages in all the quadrants, dilated and tortuous retinal veins and optic disc edema, and the localized area of retinal whitening along the distribution of a branch retinal artery, and the NCT was also normal. In the other eye as well, we can see areas of focal arteriolar attenuation, and along with them some degree of tortuosity present. And on the OCT, there's a macular edema is seen in the right eye with a CMT of 582. The visual prognosis was explained to the patient, and then later the patient was planned for 3 monthly injections of ranibizumab, but the BCVA just improved to finger counting at 3 meters from finger counting at half a meter, and along with that the patient was advised lifestyle and preventive measures, and the patient is kept for routine follow-ups to look for any subsequent neovascularizations. In my discussion, I would like to state a systemic review which was conducted by Pina et al. In Italy, which included 29 patients of combined BRAO and CRVO from the past 3 decades. The study found that among these 29 cases, 17 had an underlying risk factor. 2 of them, the events were triggered by some strenuous exercise, while the 10 had no underlying identifiable risk factor. And currently, insignificant evidence is available to establish a standardized treatment approach for this rare concurrence. Thank you.
Thank you very much. Can we have Dr. P. Lakshmi as well for the other presentation? Any questions in the panel? Thank you.
Good afternoon, everyone.
Invite Purvi Gandhi on the other stage also.
Good afternoon, everyone. Today I am presenting a case on anemic retinopathy. Coming to about 30% of patients of anemia usually show fundus lesions. The common ocular features are conjunctival pallor, retinal abnormalities, and posterior pore abnormalities. Exact mechanism is not clearly known. Coming to case proper, a 21-year-old male presented with diminution of vision in right eye since 1 day. History of passage of blood in stools for 2 days a week ago. Negative history for fever, bleeding gums, loss of appetite, and recent weight loss. History of blood transfusion for anemia in October 2020. Negative history for ocular trauma and systemic abnormalities are no systemic abnormalities. General examination, patient is conscious, coherent, and cooperative. Deaf and mute, pallor is present. Vitals are within normal limits. Coming to ocular examination, vision in right eye is perception of light. Vision in left eye is 6/6 and N6. Anterior segment is normal in both right eye and left eye. Pupil showed relative afferent pupillar defect in right eye. Intraocular pressure through non-contact tonometry is 24 millimeters of mercury in right eye. Coming to fundus of right eye, with good media clarity, vertically oval, medium-sized disc with cup disc ratio of 0.2:1, dilated tortuous veins, multiple flame-shaped hemorrhages with white-centered suggestive of rod spots, and subhyaloid hemorrhage is present superior to macula, and macular edema is seen clinically. Fundus of left eye is within normal limits. Optical coherence tomography of right eye showed cystic spaces in the macula with neurosensory detachment and subhyaloid hemorrhage with backshadowing. However, OCT of left eye is within normal limits. Patient was investigated systemically where it revealed low HB and low RBC count. Peripheral smear showed microcytic hypochromic anemia with pencil rods. Iron profile showed deranged serum iron, serum ferritin. Vitamin B12 is also deranged. It is in the lower side. USG abdomen suggestive of mild splenomegaly. Patient was transferred to physician where he was transfused 2 pint of RBC after over 3 days. On day of presentation, the fundus picture of patient is like this with vision of perception of light. However, post-transfusion, patient had vision of 6/18 with resolution of macular edema. It is confirmed on OCT where there is resolution of macular edema with presence of subhyaloid hemorrhage. What's unique in my case is macular edema and other signs got resolved after treating the patient with blood transfusion. Vision also improved. Clinical implication, ophthalmologist has crucial role in management of anemia patients. Timely physician referral and management can save patients' vision and life as well. Take-home message is retinal findings in anemic retinopathy are flame-shaped hemorrhages, cotton wool spots, rod spots. Vision is not affected unless macula is involved. Retinopathy prevalence increases with severity of anemia. It resolves the treatment of underlying anemia. Thank you.
Can you tell me why the other eye is not affected if it is a case of a systemic disease? Anemia, both the eyes should get affected.
Yes,
so can you give an explanation in your case why one eye? So would you like to revisit your diagnosis to something else or it's an anemic retinopathy?
Like we asked the physician, but they told cause of anemia only had led it. They have told it, sir,
But other eyes should
should
also
also be
have some,
affected. Yes,
yeah,
sir.
so that is one of the things what you have to look into.
Okay, sir. Thank you, sir.
Good afternoon, everybody. I am going to present my case, recognition and management of systemic vasculitis with CRVO as a warning call. I am presenting a case of 61-year-old male who complained of right eye diminution of vision for 2 weeks. He is known case of hypertension, interstitial lung disease, benign prostatic hyperplasia, and P-ANCA positive vasculitis. He is already treated with pulmonary TB, COVID pneumonia, and he was positive for HBV and HBC. He was already medicated with IV cyclophosphamide, IV MP, tabceptran, tenofovir, and was on maintenance dose of 12.5 mg prednisolone. His vision on first visit was 6/12 part and IOP was 11 mm of Hg. On examination, his lens showed immature senile cataract with nuclear sclerosis grade 2. Disc was mild pallor. Foveal reflex was dull, which was confirmed on OCT as cystoid macular edema, with fundus showing dilated veins and mid-periphery dot plot hemorrhages. His left eye showed immature senile cataract of grade 2. Now we made the differential of ocular ischemic syndrome with cystoid macular edema or CRVO with cystoid macular edema. So we did the thorough workup with BP wing 1110 by 60 mm of Hg, CT angio and MRI neck was normal, but MRI brain showed chronic microvascular ischemic changes. So we planned him for first intravitreal injection. Now 1 week post-op his vision was 6/9, but on one post-op he came with complaints of diminution of vision for 2 weeks and his vision was 5/60. We noted the cotton wool spots and the ischemic component, that is hyperreflectivity and thickening of inner retinal layers. Now we made the probable diagnosis of secondary vascular occlusion post-vasculitis, that is ocular flare-up. Now we advised hypercoagulative profile and complete uveitic profile. He was under the care of nephrologist, so we planned him for FFA clearance and stepping up the steroids with planning of for IVMP, 1 gram slow IV infusion, 3 doses. Now FFA showed staining of vessels and dull foveal reflex. 2 week post IVMP, his vision was 6/24, his cotton wool spots were resolving and he was switched to mycophenolate myofertil. 2 months post IVMP, he again came with edema, so we planned him for second dose of intravitreal injection aflibercept. Now, 1 month and second month post-op, his vision was improving. In between, the patient consulted higher center and he was advised to continue same treatment and look for neovascularization. 3 months post-injection, the patient came with vision of 6/24 and his foveal reflex was dull with cystoid macular edema and he was on oral dose of 10 mg of steroids. So we planned him for intravitreal injection Ozurdex. Now, on his last follow-up, that is of 10th of March, his edema is reduced, is presently on 7.5 mg oral steroids and is under the care of nephrologist now, for his systemic evaluation. Now, the take-home message here is we need to keep a keen eye to look for the signs of vasculitis. Also, the collaborative effort between rheumatologist and ophthalmologist is very necessary. Also, it is not a one-point treatment approach. So, we need to long-term follow up the patient like he follows up with rheumatologist. Thank you.
What was the systemic disease? Why was the patient be given hepatitis B treatment?
Sir, he was HPV, remote HPV and C positive.
So if it's positive, then why are you giving so much immunosuppression?
So because his edema was reoccurring.
So the treatment for vasculitis is a local steroid or a systemic immunosuppression? You already the patient is on cyclophosphamide. So why did you shift him to rituximab?
So we didn't shift to rituximab because he was having HPC positive. Rituximab causes liver, couldn't be given in liver failure patients. So he was planned, but because of the liver condition, he was not given.
So why do you need to give steroid if you think the patient is hepatitis B and C positive? Then just give local Ozurdex. Why do you want to give systemic treatment for one eye? Either the patient has systemic vasculitis, the eye becomes a window to the brain. If the brain has active vasculitis, then it is life-threatening. But if it's a local one-eye pathology, the local steroid would work. Why would you want to give oral steroids in a hepatitis B and C positive patient?
So like we consulted the nephrologist.
No, I'm just thinking aloud. You should, as an ophthalmologist, don't think only of the eye, think of the systemic. So if you have a patient who has systemic pathology, then higher immunosuppression is required long-term. Short-term steroid is never going to be treated in a vasculitis because the vasculitis will last 5 to 10 years. If it's a local pathology, one eye involved, then the local steroid would do in an active infection. Just think about it.
Just add on to what Amit is saying, ki you gave anti-VEGF as the first line of treatment in this
Yes, sir.
patient.
So because earlier we were
So the first line should be Ozurdex, local steroid, as compared to anti-VEGF in cases of vasculitis. So our take home is ki steroid, local steroid first, then go ahead with the systemic immunosuppression.
If you have systemic inflammation, then you give systemic steroids. If that is contraindicated, give local steroid. Anti-VEGF will not reduce the local inflammation. In an inflammatory disorder, steroid will work better than anti-VEGF.
And actually,
Yeah, so
posterior subtenon steroid also works very nice in these kind of cases. So it's not necessary that you give intravitreal Ozurdex. You can also give a PST tricot, and many cases will respond. If it doesn't respond, then you can go ahead and give an intravitreal steroids.
See, macular edema is never an emergency. You can treat macular edema with a diabetic and all. You can wait for a month and control the systemic features. So even if you go by the focus trial in uveitis, macular edema is never an emergency.
So like earlier he didn't had cotton wool spots. So we were suspecting ocular ischemic syndrome because he had mid-peripheral
No, ocular ischemic syndrome will only occur in vasculitis. The disease is systemic. It's not a localized disease. Okay, so localized disease can be treated locally. Systemic has to be treated systemically. So if you're giving short-term steroid for systemic vasculitis, with no systemic inflammatory, with active infection, it's better to treat locally. Okay,
Thank you so much.
So good afternoon everyone. Today I am going to talk about thalassaemic retinopathy. So beta thalassemia is a disease per se which can affect almost all the systems of our body. The ocular manifestation can be rare but cannot be ruled out. So ocular findings are varied and can range from ocular surface disease till the retina. The retinal changes also depend upon the varied factors, among which the severity of the anemia is one of the key factors which determines the severity, which determines the disease course. So today I am going to discuss one such case in which the severity of the disease determined the course of the disease. A 17-year-old female presented to our OPD with a chief complaint of diminution in vision in both the eyes since 1 year. She had a past episode of weakness and anorexia for which she was admitted. Her hemoglobin level dropped down to 2 milligram per deciliter, for which she received a packed RBC transfusion, and through thorough investigation a diagnosis of sickle beta thalassemia with vitamin B12 deficiency was established. Currently her best corrected visual acuity in both the eyes was 2/60 and anterior segment findings were within normal limit. On posterior segment evaluation we could find multi-layered hemorrhages with the heme and serous collection. So with the clinical picture we had a diagnosis of anemic retinopathy in our mind. So we decided to do OCT and FFA for the patient. The OCT showed multi-layered hemorrhages, and the FFA thankfully didn't show any peripheral neovascularization. So at this point of time, we had two treatment options with us, to either to plan for a vitrectomy or to go for a systemic control. We decided to go for systemic control and wait for heme to resolve. We continued our systemic therapy of tablet folic acid 5 mg daily and capsule hydroxyurea 500 mg twice a week. We followed up our patient on 2 weeks interval, and hemorrhages were resolving at each follow-up visit. This is the fundus photo image at 2 months follow-up. The visual acuity at this point of time was 6/36 and hemoglobin levels were 9.5 milligram per deciliter. So my case is unique in the severity of the retinal finding associated with the anemia and associated B12 deficiency, and also such an alarming visual loss was restored just by improving the systemic condition of the patient. We could clinically imply from this case that sometimes two seemingly different appearing condition can be a different spectrum of a single clinical condition, and also a nutritional deficiency can also cause a devastating complication. A multidisciplinary approach is very much essential to deal with such cases. So we can take home a message that sometimes no active intervention can also be a mainstay of treatment and can show miraculous response. Thank you, sir.
What are the platelet levels?
Sir, platelet level are normal.
P. Vidya, I think your photographs were excellent. It's in cover photographs. And why didn't you go for a surgery once the hemoglobin was cleared? Because lastly what we saw, a lot of fibrosis has occurred.
We never intervened the patient.
So if you could have intervened after the hemoglobin would have corrected, then you would have given some kind of vision to the patient.
Yeah, actually the patient was 17-year-old. So actually, in the production of PVD is quite difficult in this patient.
That's not a reason to not to take up surgery.
So we had two clinical options, but since the patient was improving with the systemic control, so we decided to wait furthermore if the patient could improve more. And then
if you have to take a surgical intervention, what will be the right time in this patient to go ahead with the surgical intervention?
Once there is clear, we can see the media clearly. Once the media clears out and the hemorrhage is set.
What is the time period you will try to intervene? 1 महीना, 2 महीना, 6 हफ्ते?
6 months.
6 months is too long a period. I mean, when you will like to intervene in this?
You can make it weeks instead of months.
3 weeks.
Your 3 to 4 weeks. Thank you.
Good afternoon, teachers. Today I'm here to discuss an interesting case of lipemia retinalis in a 30-day-old infant. So lipemia retinalis is a retinal manifestation of chylomicronemia. Ophthalmic features are creamy white discoloration of the retinal vessels, which start in the peripheral vessels in mild cases and involve central retinal vessels in established cases. Though lipemia retinalis does not affect the vision per se, but it must be taken into account since it is associated with severe but easily treatable metabolic disorder. So a 30-day-old female child brought to ophthalmology OPD by her parents as a pediatric referral for ROP screening, since she is a early preterm baby with low birth weight and resolved sepsis. Marital history is second-degree consanguineous marriage, and gestational history of the mother was normal. Family history shows no known comorbids in the family members. Coming to ocular examination, anterior segment examination of both eyes were normal. Coming to fundus examination, both eyes media clear, disc size, shape, color, margin normal, cup disc ratio 0.3:1, vessel showed milky white dilated vessels in both eyes, AV ratio 2:4, macula and F are normal. This is the fundus picture showing milky white dilated vessels. And on examination of systemically, we can see multiple eruptive xanthomas over the cheek and all over the body of the baby. And we got a diagnosis of lipemia retinalis. And since it is a genetic disease, we screened the family members. Mother and father were normal, but similar fundus findings were seen with her elder sister with no systemic manifestations. Lipid profile of the 30-day-old female child shows serum cholesterol of 1320 milligrams. Serum triglyceride is 4700 and serum HDL is very low. Ultrasound abdomen was normal steady and genetic analysis showed lipoprotein lipase deficiency. And treatment we gave medium chain fatty acid based formula feed, and we changed to low fat skimmed milk, avoided breast milk, and every review every month. Take home messages: this case emphasizes the importance of preterm pediatric case ophthalmic screening and also term babies with risk factors. Thank you.
What is the lifespan of some children?
With better dietary control, we can expect more, sir.
Thank you.
Thank you, sir.
Nice presentation. Can I ask Bharti Niman?
A very warm good afternoon. So I am Akshat. I will be presenting a case of retinitis in hand, foot, mouth disease. I'll be using abbreviation HFMD for the same. So HFMD is an acute onset contagious viral infection caused by Coxsackie virus of various serotypes. It presents with maculopapular rashes or vesicles on upper and lower limbs with involvement of perioral skin and acute onset fever. Ophthalmic manifestations, though rare, can be severe, such as vitritis, chorioretinitis, hemorrhagic occlusive vasculitis, and even exudative retinal detachment. Though the condition is spontaneously resolving, but the topical and systemic steroids have been seen to expedite recovery, as we see in our case. So my case was a 2-year-old girl child, resident of Odisha. She presented with the chief complaints of both eyes, sudden painless diminution of vision for 3 days. Basically, the patient's parents had observed sudden change in visual behavior. She also had history of fever and papular skin rash over upper and lower limb, and she was admitted in pediatric ward for last 1 week for the same and was on treatment. Her anterior segment was within normal limit. Pupil was reacting to torchlight with no relative afferent pupillary defect. This was the fundus photo at presentation. The right eye had dilatation and tortuosity of second order venules with deep retinal hemorrhages and a white to yellowish lesion suggestive of necrotizing retinitis. Left eye was even worse with extensive venular tortuosity and dilatation in all four quadrants with surrounding retinal hemorrhages and inferior exudative retinal detachment. So with this clinical presentation, we made a provisional diagnosis of CMV associated retinitis, and primary treatment of intravitreal ganciclovir with dexamethasone was given. In the same sitting, left eye vitreous biopsy was sent for polymerase chain reaction, which later came out to be negative for HSV1, VZV and cytomegalovirus infection. And after 1 dose of intravitreal and further 1 week of oral steroid, 5 mg per ml prednisolone, we noticed a remarkable improvement in both the eyes with complete resolution of retinal lesions in right eye and resolving vasculitis in left eye. The OCT done at the same visit showed the consolidated retinitis lesion involving all the layers of retina and choroidal thinning. So the dramatic response to a minimal dose of steroid with negative PCR of CMV prompted us to modify our diagnosis, and we changed our diagnosis to Coxsackie virus associated retinitis, and only 3 months of systemic steroids were given. And after 3 months of systemic steroids, both eyes showed complete resolution of lesions with significant improvement in visual behavior. So as compared to earlier published cases which showed mostly unilateral involvement, our case showed bilateral involvement with retinitis lesion being full thickness and distribution was diffuse and multifocal. Also the exudative retinal detachment in our case was inferior compared to the macular involvement retinal detachment in earlier cases. Also it was till now the youngest documented case of ocular involvement in hand-foot-mouth disease. So the close differentials were CMV retinitis, but the faster response to minimal steroid and seronegativity ruled out its present, while the extensive hemorrhages and presence of retinitis at posterior pole pointed against acute retinal necrosis. So take home message, HFMD can manifest with skin changes and asymmetric ocular involvement of hemorrhagic retinal vasculitis and exudative retinal detachment, and intravitreal and systemic steroid and intravitreal anti-VEGF can be the treatment option with favorable response.
Thank you. How did you come to a diagnosis of Coxsackie virus infection?
Like, since it was a systemic illness also, it was a typical case of hand-foot-mouth disease.
So what are the features of hand-foot-mouth disease you have?
I have presented, the patient had the 1 week, prior to 1 week, she had the upper and lower limb maculopapular rashes and the acute onset fever, for which she was treated in pediatric ward for same.
Okay. Dr. Bharti, please.
Thank you.
Good afternoon. I'm going to be talking about type 2 macular telangiectasia with CNVM in young female. So coming to macular telangiectasia, it has been classified into 3 types. Though it is a very rare condition, amongst the 3 types, type 2 is the most common. It is bilateral, acquired and slowly progressive degenerative condition of the macula. Mactel type 2 is generally seen in perifoveal area. The term mactel is often used to refer to mactel type 2, and most commonly it occurs in the age group of 50 to 70 years. So though the etiology remains mostly unknown, but it has various hypotheses, theories have suggested it to be a primary neurovascular degenerative disease which affects primarily the Muller cells, which are the principal glial cells in the retina, and the RPE cells, as well as retinal vessels, leading to loss of the photoreceptors. And CNVM appears in the last stage of the disease progression. This is a stage at which treatment needs to be given. So coming to the case, it is a 38-year-old female complaining of diminution of vision in both eyes in 6 months, insidious in onset and gradually progressive. There is no history of trauma, redness and pain. She is a known hypertensive since 2 years on medication. But since the presentation of macular telangiectasia, like we suspected macular telangiectasia, we have also told her to get investigated for diabetes, where she was diagnosed as diabetes because her HbA1c came out to be 9.88%. So on ocular examination, her visual acuity was 6/60 in right eye and 6/18 in left eye, remaining everything of the anterior segment to be normal. But coming to the fundus examination, the right eye showed fundus shows foveal and perifoveal ectatic vessels with venules diving at right angles into deeper retinal layers. Usually the macular, the vessels near the macula, they taper off and they're not present in the foveal area. But here, because they're ectatic vessels, and they do not taper, it looks like they're diving at right angles. And there's grayish discoloration of the perifoveal area. And RPA hyperplasia and pigmentation can be seen at the superior temporal fovea, where the disease usually starts, and with mild scarring in the right eye. So disease is worse in the right eye compared to the left eye. And we did fundus autofluorescence to see the amount of RPE cell damage which is there. So FF shows areas of hyperautofluorescence in the area of RPE atrophy and hyperautofluorescence suggestive of stimulated RPA. And we did OCT and OCT-A, which is the diagnostic test modality in this. So OCT shows loss of architecture of inner retina with type 2 CNVM in the right eye. And OCTA superficial layer shows venules diving at right angle into the deeper retinal layers. With dragging of vessels to the epicenter, and outer retinal scan shows fine lacy network, which is not supposed to be present in the outer retina as it is avascular. And similarly in the left eye, but right eye is more affected than the left eye. So what is unique is, usually the age of presentation is 50 to 70 years, but this lady being young, it just makes it a very rare thing, but there has been cases with younger presentation as young as 18 years also. And because she's diagnosed as uncontrolled diabetes, we have to be vigilant in ruling out systemic conditions as the MACTEL project, which is the largest project, and it is an ongoing trial. It has shown evidence of diabetes as high as 28% and hypertension 52%. So it is mandatory to do all these primary systemic evaluation to help the patient. And the take-home message is MACTEL is a neurodegenerative disorder with telangiectatic vessels in the periphovea entering at the right angles into inner retinal layer. Neurodegeneration subsequently leads to RPA damage and migration, eventually leading to subretinal neovascularization. Currently, no treatment is advised till the stage of neovascularization. Our patient having bilateral CNVM was advised for bilateral anti-VEGF injections. Diabetes and hypertension is thought to be a contributing factor. Thank you.
Next we have Dipansha Gupta, then Priyanka Mohanty, Harshit C, and then Ahan Gupta. Please, all the speakers come in the front row and be on the dais next, because we are running short of time.
Good afternoon, everyone. The topic for my case presentation is eyes, the windows to diagnosis and complications of leukemia. So leukemia, as we know, is a malignant disease in which there is clonal proliferation of the immature leukocytes. Eyes can be one of the most frequent extramedullary location, and its features could be the inaugural manifestations. And these include dilated tortuous veins, hemorrhages, cotton wool spots, leukemic infiltrates, and many others. So, a 25-year-old gentleman presented to us with a complaint of sudden diminution of vision in the left eye since 4 days. There was no history of trauma or any significant history. The vision in the right eye was 6/7.5, whereas in the left eye it was 6/12 and 10. The anterior segment was normal, but in the posterior segment we could see that there are dilated tortuous veins along with multiple white-centered hemorrhages. And so the OCT was advised for both the eyes, where we could see that there are intraretinal hyperreflective lesions. So these are rot spots. There are multiple differentials of rot spots, which include infective endocarditis, leukemia, anemia, myeloma, and many others. So to differentiate these, routine lab investigations were advised, where we could see that the patient has mild anemia and granulocytosis on CBC, whereas the CML showed that there is proliferation of the immature blast cells, and hence the suspicion of CML was there. That is chronic myeloid leukemia. and so the urgent referral to hemato-oncologist was made, where he could see that the patient has splenomegaly along with translocation of the chromosome 922, that is BCR-ABL gene, and hence confirming the diagnosis of CML. So the patient was started on oral imatinib, and after 3 months when he presented to us, the vision was improved to 6/6 in the right eye, whereas 6/6 part in the left eye. The fundus finding and the OCT findings had also significantly improved. After 1 year, the vision was normal, that is 6/6 in both the eyes, the fundus was okay, and the blood counts were also within normal range. Now, another patient who presented to us, now she was a known case of ALL this time and was in complete remission since past 2 years. This time she presented to us with a sudden onset painless of diminution of vision in left eye since 15 days. The vision was decreased in both the eyes with grade 3 RAPT in left eye. The anterior segment was normal, but in the posterior segment we could see that there are edema in the disc and the surrounding area along with pre-retinal hemorrhages. So, the MRI brain and orbit was advised to see if there is any secondaries present in the brain or there is any CNS involvement. And we could see that there is an intraocular elliptical mass lesion in the posterior aspect of the left globe that suggested the presence of leukemic infiltration. So, the diagnosis of ALL relapse with leukemic infiltration was made. So, it's important to be aware that this kind of life-threatening disorder may be an initial presentation to an ophthalmologist as well. But we couldn't diagnose the disease for the first time and the relapse by just simple fundus examination. So all leukemia patients should have ophthalmic assessment at diagnosis and after 6 months also. Many patients have no symptoms despite ophthalmic involvement, which could be an early sign of CNS disease or relapse. Thank you.
Any questions from the panel? Priyanka Mohanty.
Can you have Harshita stand by?
Good afternoon, everyone. I'm going to present my PG Capsule case report on from eye to system lupus retinopathy in a new SLE case. SLE, as we know, is a chronic autoimmune disorder causing systemic inflammation and predominantly affects women of childbearing age. Ocular involvement is common in approximately 1/3 of patients but is often under-recognized, and the spectrum ranges from mild dry eye to severe retinal vasculitis or choroidopathy. And the risk factors for ocular involvement are presence of nephritis, APLA, hypertension or female gender. Ours was a case of 20-year-old female with progressive diminution of vision in both eye for 2 weeks associated with ocular discomfort and floaters. No history of trauma. On systemic examination, she had malar rash that worsened with sun exposure for past 1 month. Intermittent joint pain and stiffness was also present, and fatigue and occasional low-grade fever. There was no significant past medical history, and the patient was not pregnant at that time. On ophthalmic evaluation, the visual acuity was finger counting at 1 meter with PR accurate in right eye and finger counting at 3 meter in left eye. IOP and anterior segment was within normal limits. On fundus examination, there was tortuous retinal vessel and multiple cottonwool spots in both the eye with intraretinal hemorrhages. On further systemic investigation, we found her to be positive for anti-nuclear antibody and anti-DSDN antibody. Complement level was low and ESR CRP was elevated. Rest other blood examination was within normal limits. On ocular investigation, fundus autofluorescence was performed, and on OCT macula, there was intraretinal cyst more in the right eye and cottonwool spot in the both eye with macular edema. From medicine side, the patient was started on oral steroid with hydroxychloroquine and oral anticoagulant aspirin was started. On follow visit, her vision has improved to 6/36 partial in the right eye and 6/9 partial in the left eye with resolving macular edema. The systemic medication was continued. Now coming to what is unique in my case is that early onset lupus retinopathy, especially in a 20-year-old at the presentation, is uncommon, and ophthalmic manifestation served as a critical systemic clues for SLE diagnosis, and the retinal changes suggest an immune-mediated vasculopathy with diagnosis in the line of possible vasculitis or APLA, and there was effective response to systemic steroid and HCQ, and it highlights the importance of a multidisciplinary approach. And as clinical implication is we can see that if we are starting a patient on HCQ, if there is no additional risk factor, we should begin monitoring after 5 years of drug therapy. But if there is impaired renal function or increased dose of hydroxychloroquine or chloroquine is used, we should begin monitoring after 1 year of drug therapy. We can go for OCT as an initial evaluation, and if it comes abnormal, we can go for HFA. And if HFA is also abnormal, we can go for multifocal ERG. And if we found toxicity in any of the 3 cases, we should stop the drug and look for an alternative drug. My take-home message is that ocular manifestation can reflect overall disease activity, especially in young patients with unexplained vision loss. Lupus retinopathy may indicate an underlying vasculitis or antiphospholipid antibody syndrome, which requires urgent evaluation on a systemic basis, and prompt systemic immunosuppressive therapy can reduce the need of invasive ocular procedure, and collaboration between different departments is crucial for optimal patient outcome. There is no financial disclosure associated. Thank you.
Harshita and then Mukta. One question, your diagnosis came from your skin lesions or the ocular findings gave you the diagnosis?
Sir, the patient presented directly to opthal OPD first, then we sent to medicine and then to derma.
Thank you.
Good afternoon, everyone. Title, The Silent Stroke in the Eye, a case of central retinal artery occlusion revealing a systemic atherosclerotic risk. Coming to the introduction, central retinal artery occlusion is nothing but the stroke of the eye, presents as sudden, painless monoocular loss of vision. Atherosclerosis and embolism are leading causes. Early recognition is crucial and it signals high stroke risk. Multidisciplinary approach improves both ocular and systemic outcomes. Coming to the case details, it is a 61-year-old female presents with sudden painless vision loss for few hours, no history of stroke or diabetes or hypertension. The vision in the right eye was CF 2 meters, and she was having grade 1 RPD. The fundus showed retinal pallor, cherry red spot, and attenuated vessels. The OCT had inner retinal thickening and hyperreflectivity, and FFA had delayed arterial filling. The carotid Doppler showed right CCA, common carotid artery non-flow limiting plaque, and MRI had no acute infarcts. Lipid profile showed increased LDL. Coming to the final diagnosis, it is CRAO of right eye, secondary to systemic atherosclerosis. The immediate treatment was ocular massage and hyperventilation and anterior chamber paracentesis. IOP lowering agents like temolol and brimodin can be given, and antiplatelets like aspirin and clopidogrel can also be given. Long-term treatment with statins and BP control in patients with hypertension to follow up with neurologists and cardiologists. This was the fundus, which showed, the right eye showed pale retina and attenuated vessels. OCT showed inner retinal layer thickening and hyperreflectivity. What makes my case unique is CRAO is the first sign of silent systemic atherosclerosis. Even non-flow limiting carotid plaques can cause embolic events. Multidisciplinary care prevents a future stroke. Coming to the clinical implication, CRAO is just not an ocular emergency, it's systemic warning sign. Multi-speciality collaboration is crucial. Immediate ophthalmic intervention combined with neurological and cardiovascular workup is needed. Carotid Doppler is essential in all CRAO patients, even if no significant stenosis is found. Early diagnosis and systemic intervention can reduce stroke risk. Take-home message, CRAO is nothing but ocular stroke or systemic stroke risk. Anterior chamber paracentesis can be sight-saving. Every CRAO patient requires cardiovascular evaluation. Early intervention prevents stroke and systemic complications. No financial conflicts of interest. Thank you.
So, Akshata, should an MRI be done in all patients of CRAO?
It's better we do it.
So with contrast, what study needs to be done?
For infarcts.
It's a diffusion study, you don't write diffusion study. Diffusion study for MRI. Not a contrast, not a normal MRI. A diffusion
angiography.
DWI. DWI to look for 7% of CRA will have a minor infarct in the brain.
Yes. Thank you, sir.
Good evening, ladies and gentlemen. Today I'll be presenting a case presentation titled Popping Out of Sclera. So an 18-year-old boy presented to the Oftal OPD with complaints of redness in the right eye associated with excruciating pain and diminution of vision. Vision in the right eye was 618, IOP on GAT was 16 mm Hg, sclera was congested, and anterior segment examination was within normal limit, and the anterior vitreous face showed presence of cells. Vision in the left eye was 6.6, intraocular pressure on GAT was 15 mm Hg, and other examination was within normal limit. Here's a slit lamp picture which shows diffuse congestion and associated with pain, so we suspected a diagnosis of scleritis. On dilated fundus examination, we can see presence of disc edema, and in the inferotemporal quadrant, a black homogeneous mass was present in the inferotemporal quadrant. So a presumptive diagnosis of a ciliary body melanoma was made, and the patient was advised further investigations. On ultra-wide field angiography, we can see presence of disc edema and leakage of fluid from the capillaries. In the inferotemporal quadrant, we can see a hyper reflective mass which shows no leakage. So a diagnosis of ciliary body melanoma was ruled out, and the B scan shows the presence of a cyst with a central scolex, leading us to a diagnosis of neurocystic sarcosis. Further, we did an MRI which shows presence of the neurocystic sarcosis in the region of the ciliary body. So we made a diagnosis of ciliary body neurocystic sarcosis. Now, how to manage this case? Surgical management or medical management? We went ahead with medical management and started the patient on tab albendazole 400 mg BD and systemic as well as topical steroids and hometropin eye drops. 2 days later, we saw that the cyst had migrated from the ciliary body into the subconjunctival space and was popping out of the sclera. Now, 2 weeks later, we see that this cyst has lodged itself in the subconjunctival space, and at this point of time is when we decided to do a surgical excision of the cyst. After post-excision, the redness and pain of the patient had resolved, and the popping of sclera had also resolved. So it was a changing diagnosis. There was a management dilemma. Commonly, the neurocystic sarcosis is seen in the vitreous cavity or in the subconjunctival space. It's rarely seen in the ciliary body. All is well when the patient is well. Here is a video showing the excision of this cyst.
Any questions? Any questions, Amit? You can ask any.
So normally in patient lucky we don't give albendazole for intraocular investigation. The patient was lucky that the patient didn't have. So how do you say that this was histopathology done of the cyst?
No, sir, histopathology was not done of the cyst.
So we need to prove it's cystic sarcosis. We need to do a histopathology of the cyst whenever you remove it. And if it ruptured through the sclera, it's a rare report, you should report it, but always a biopsy needs to be done of the cyst. What should you expect? And albendazole we normally don't give. Because it can lose the eye with the
lose the eye. Cyst can die and cause the inflammatory reaction.
Thank you. With this, we end this session and we invite judges for the next retina session, and all the presenters can come here on the dais and we can have a group photograph.
You come back.